Hi, and welcome to our presentation on non-squamous, non-small cell lung cancer. Our names are Maddie Fussell, Ariel Flowers, and Alana Abdu. We are team number 15 in our cancer biology class.
So we're going to begin by talking about basic cancer research. There are going to be two main types of lung cancers, non-small cell and small cell cancer. Lung cancers are classified by tissue and cell type of origin, and lung cancers in particular are classified as carcinomas. Carcinomas are cancers that begin in the epithelial cells, particularly in the linings of organs. Non-small cell carcinomas are found in the linings and surfaces of lung airways, often the bronchi, bronchioles, and alveoli of the lungs. Non-small cell lung cancers can be further classified as adenocarcinomas, squamous carcinoma, large cell carcinoma, bronchoalveolar, and mixed histological types. Adenocarcinomas are also referred to as non-squamous cell cancers. The tumor type we are focusing on is non-small cell adenocarcinoma. There are a variety of tumor suppressor gene mutations that can lead to the development of lung cancer. The most common tumor suppressor gene mutation that occurs in individuals with a history of smoking is a mutation in the TP53 gene. It also affects the majority of those with non-small cell lung cancer. TP53, also called P53, is considered the guardian of the genome because it controls DNA repair mechanisms, cell cycle arrest, cell apoptosis or cell death, and the cell senescence. This is just when the cell stops dividing, but it does not die. Tumor suppressor genes work to regulate cell growth by maintaining cell cycle checkpoints. Therefore, a mutation in a tumor suppressor gene like P53 results in excess and inappropriate cell growth. Tumor suppressor gene mutations are considered loss of function mutations, meaning that the two copies of the tumor suppressor gene must be lost for a cell to become mutated. Non-small cell lung cancer is a somatic cancer, so that means that two mutated copies of a tumor suppressor gene must occur in the same cell in order for non-small cell lung cancer to develop. What are hallmarks of cancer? So the hallmarks of cancer describe the distinct characteristics that cancer cells acquire when developing to form a tumor. There are 10 established hallmarks of cancer, 4 of which are emerging and enabling hallmarks. The 6 original hallmarks of cancer are sustaining proliferative signaling, resisting cell death, inducing angiogenesis, enabling replicative immortality, activating invasion and metastasis, and evading growth suppressors. The 4 emerging hallmarks are deregulating cellular energetics, avoiding immune destruction, genome instability and mutation, and tumor-promoting inflammation. So we got to ask which hallmarks are affected by a mutation in the P53 gene. Well, there could be 3 hallmarks of cancer that could be affected by this kind of mutation. The first hallmark that may be affected is the cell's ability to evade growth suppression. Tumor suppressor genes become inactive when they're mutated. And when P53 is mutated, it is inactivated and can no longer maintain cell cycle checkpoints. This means that the cell cycle can no longer be arrested by P53, which leads to continuous and uncontrolled cell division. Without the ability to stop the cell cycle when appropriate, a cell acquires the hallmark of growth suppression evasion. The second hallmark that can be affected is resisting cell death. One of the functions of P53 is inducing cell apoptosis or cell death, when appropriate. Induced cell death may be appropriate when errors in cell replication that cannot be easily repaired are detected. When mutated, P53 no longer has the ability to get rid of cells with replication errors, and leads to the cell's ability to resist cell death. The last hallmark that may be affected by a p53 mutation is genome instability and mutations. When cells with mutations and errors in replication resist cell death and continue cell division, the daughter cells that are produced also contain those mutations and errors. So that means that the mutations that are made are passed from cell to cell, leading to genome instability or high rates of mutations and resulting in the resulting cells. What hallmark cancer does bevacizumab, also called Avastin, target? So we chose to focus on how Avastin is used to treat non-squamous non-small cell lung cancer. Avastin is a targeted therapy called an angiogenesis inhibitor. It targets the protein VEGF, which stands for vascular endothelial growth factor, by neutralizing it. VEGF is a protein that's normally found in all cells and supports the growth of new blood vessels. When VEGF is expressed under normal conditions, it is referred to as a proto-oncogene. But when it's mutated and overexpressed in a cell, VEGF becomes what is known as an oncogene. Cancerous cells that comprise tumors often acquire mutations in their proto-oncogenes, which turn them into these oncogenes. And this contributes to tumor heterogeneity, meaning that because there are many cells that make up one tumor, those cells often have varying genetic makeups. So different cells within a single tumor may acquire different hallmarks of cancer. Because of this, one whole tumor may have all the hallmarks of cancer, but not every single cell in that tumor will have every hallmark. More specifically, Avastin targets a tumor's ability to induce angiogenesis, or the tumor's ability to attract a new blood supply to sufficiently grow. Without this vital hallmark of cancer, individual cells of a tumor may be prevented from growing. Because Avastin does not target a specific part of the cell cycle growth, it is considered a cell cycle nonspecific drug. This means that it can work against cancer cells at any stage of the cell cycle.
The next topic we chose to discuss was cancer epidemiology. So, what is the public health problems with lung cancer? It is the second most common cancer for both men and women, and the leading cause of death. The average age at diagnosis is 70 years old. Men are more likely to develop lung cancer than women, and African Americans are more likely to develop this cancer compared to Caucasians. The incidence of lung cancer has decreased due to people quitting smoking or less people starting. And this is the same for the death rate, which has decreased due to fewer people smoking and advances in early detection and treatment. Some lung cancer statistics is the number of new cases in 2024 is 234,580, and the number of deaths is 125,070 in the United States. Different statistics from 2022 found that in China, there was an incidence of over 1 million and 733,291 cancer deaths. In the U.S. in 2022, the incidence was 226,033, and cancer deaths was 127,653. In the world, lung cancer had an incidence of over 2 million, and the death rate was around 1.8 million. Non-small cell lung cancer comprises around 80 to 85% of all lung cancer patients. So, for the observational study I found, it discussed the association between smoking and lung cancer. It was a prospective cohort study with around 76,304 postmenopausal women aging from 50 to 79. The study included a variety of different ethnicities, and people were enrolled between the years of 1993 and 1998. The study used 40 different U.S. clinical centers to collect their data. The average follow-up year was around 10 and a half years. The smoking status was collected using questionnaires, while the cancer incidence was confirmed through medical records and doctor diagnosis. The Cox proportional hazards regression models were used to estimate hazard ratios and 95% confidence intervals. Any patient who had any misleading information or missing information were excluded from processing the results. WHIO's goal was to study morbidity and mortality of lung cancer in older women. The study showed there was a significant association between active smokers and developing lung cancer. Current smokers were 13 times more likely to develop lung cancer compared to non-smokers, and former smokers were more than 4 times as likely to get lung cancer. People who stopped smoking decreased their chances of getting lung cancer, and passive smokers, meaning people who were around smokers often, had an increased risk of lung cancer. All of the data from this study supported the continued need for smoking prevention interventions. These graphs from the study show that current smokers develop lung cancer at faster rates than both former smokers and people who have never smoked before. The graph on the right includes past smokers, which shows that there were a little bit higher of a chance of developing lung cancer compared to non-smokers who are not frequently around people who smoke. In this intervention study, I focused on Avastin in small lung cancer patients. It was a randomized open-label trial that was a phase 2 trial. It had around 180 total patients that were put into 2 different groups, Avastin plus 2 other drugs, and a group that was just the 2 other drugs. The experiment was conducted in Japan at 19 sites. The patients were between the ages of 20 and 74 and were all documented with non-small cell lung cancer. All patients were expected to have a life expectancy greater than 3 months, sufficient bone marrow, hepatic, and renal function, and had no prior chemotherapy. The efficacy of the different drugs were found by looking at disease progression and the response rate. The Avastin CP group had a median of 6 cycles, while the CP group had around 4.5 cycles of chemotherapy. Next, I looked at the efficacy and cost of Avastin. The hazard ratio for progression-free survival with Avastin CP compared to just CP only was 0.61. The progression-free survival with Avastin CP was 6.9 months, while CP only was 5.9 months. Avastin CP decreased hazard of disease progression by 39%, and almost all patients who were given Avastin had a tumor response, whether that means that the tumor stayed at a constant size or shrunk. The tumor response time was shorter with Avastin CP. Looking at cost and risk-benefit analysis, Avastin costs around $345,000 and $762 per year of life gained. And the absolute risk with Avastin only increased by 0.7%, and the incidence of fatal events 2.9%. So how helpful is this intervention? It is hard to say, honestly, because Avastin does work, but it does not extend a person's life for a very long amount of time. Avastin does have a lot of different side effects. In the study, 26% of patients stopped treatment due to the adverse side effects. Neutropenia, which is having low levels of neutrophils in the blood, was the most frequent side effect in both groups, with several people have grade 4 level side effects. Leukopenia was another very common side effect. Proteinuria, which is a condition where there is too much protein in the urine, and nosebleeds were both very common in the group that had Avastin and CP compared to the group that had CP only. And here's a table showing the different side effects and the grade level of those side effects that were listed in the paper.
The next portion of our project, we're going to focus on clinical cancer research. So what is clinical cancer research? This is the research of cancer in humans with the aim to establish effective treatments, preventions, and management strategies for cancer. How do they find these strategies? They're through phases of drug testing, which can be phase 1, phase 2, phase 3. These help determine the pharmacologic efficacy and effectiveness that treatments will have on cancer patients. In these phases, we also analyze the cost and risk benefit analysis for patients. So for the clinical course and average patient experience, for clinical subtypes for the non-squamous non-small cell lung cancer, we have adenocarcinoma, which is the most common. We also have squamous cell carcinoma and large cell carcinoma. For prognosis, patients that don't take Avastin, progression-free survival is around 4.5 months, and the overall survival is 10.3 months. Patients taking Avastin, progression-free survival is 6.2 months, and overall survival is 12.3 months. For the propensity for spread, the most common spread sites are skeletal and pulmonary systems, but can also spread to areas in the brain, lymphatic, and endocrine systems. Patients taking Avastin can experience similar spread locations, but ultimately depends on the overall patient's health and stage of cancer. Treatment protocol for our targeted therapy is indicated as a first-line treatment in combination with carboplatin and paclitaxel, also known as Taxol. This drug is administered at 15 milligrams per kilogram intravenously every 3 weeks, and this was the only dosage that was found that demonstrated significant increases in the overall survival in first-line non-squamous non-small cell lung cancer. Patients are advised to continue treatment until disease progression or unacceptable toxicity occurs, and this targeted agent should not be given alone unless as a maintenance therapy. Patient experience on this drug, many studies have shown that there is improvement on progression-free survival and overall survival when in combination with these two chemotherapies. And many patients have also experienced slower disease progression and tumor reduction. Although these two components, patients have experienced a greater than 10% rate of side effects, and meaning that they require continuous monitoring. A study done in France analyzed the efficacy and safety of Avastin in patients with stage 4 lung cancer who also had asymptomatic untreated brain metastases. The first-line treatment was for Avastin plus the carboplatin and Taxol, and the second-line treatment was just the Avastin plus erlotinib. The median progression-free survival for B plus CP was 6.7 months, with the overall survival of 16 months compared to B plus E, which had a median progression-free survival of 6.3 months and overall survival of 12 months. This same study also concluded that there was a slower disease progression and tumor reduction in the Avastin plus the two chemotherapies. Common side effects include hypertension, nosebleeds, headache, hemorrhage, fatigue, rhinitis, proteinuria, taste alteration, dry skin, lacrimation disorder, back pain, and exfoliative dermatitis. These are numerous side effects, which is why patients need to be continuously monitored to manage these treatments as needed. Resistance rates can vary among patients through different genetic makeups, previous treatments, and tumor environment or location. Resistance can develop over time through alternating angiogenic pathways that do not rely on VEGF, mutations in the VEGF receptors, and through the upregulation of hypoxia-inducible factors. Next thing we're going to focus on is the rational development of Avastin. So what does this molecule target? VEGF, and we explained earlier what VEGF was and how it blocks the signaling pathways that promote growth of new blood vessels. Our drug binds to VEGF and blocks the signaling pathways that promote new blood vessels, and it also prevents the interaction of VEGF with its receptors VEGFR1 and VEGFR2. This is specific, very highly specific when targeting VEGF molecules because it's known as a monoclonal antibody that is very effective in blocking angiogenesis. Expected off-target effects include hypertension, hemorrhage, and proteinuria. VEGF is a molecule that the body naturally produces, and it plays a major role in angiogenesis and can improve oxygen flow to deprived tissues. By inhibiting VEGF, nitric oxide levels are reduced, which help relax and lower blood pressure. This inhibition also increases resistance within the circulatory system, both of which can cause an increase in hypertension. Hemorrhaging can occur through the blood vessels being weakened and it disrupts normal hemostasis processes following the inhibition of VEGF, which increase the risk of bleeding. And then finally, proteinuria is caused through the damaging of endothelial cells and podocytes in the kidneys, both of which VEGF is essential for. By damaging these cells, patients are more likely to experience proteinuria. In addition, patients with hypertension also have a risk of developing proteinuria. For the therapeutic index, when Avastin is combined with the two chemotherapies, carboplatin and Taxol, Avastin has a favorable therapeutic index. There's not necessarily a universally defined therapeutic index for Avastin, as it can vary amongst patients, but generally the effective dose for this targeted therapy is lower than the toxic dose.
Thank you so much for coming and watching our presentation. And here's just some of the references that we used as well. Thank you again.
Patients also have a greater than 10%. Sorry, my country accent came out on that one.
I'm definitely not